professor, physician, epidemiologist. I am Dr. Sri Banerjee. Hello, I'm Dr. Sri Banerjee, core faculty for the College of Health Sciences and Public Policy at Walden University. And in this video, I'll be going over inequities and trying to understand inequities through some new and relevant models. And the specific way, and when I mean models, first of all, I mean more so conceptual frameworks or theories is what I'm trying to get at. And specifically, I'll be dealing with the idea of racism. Um, and so I start off with this New England Journal of Medicine article because this is considered the premier journal with this article, Deconstructing Inequities, published in May of 2021, Transparent Values in Measurement and Analytic Choices, by Givens et al. And the reason this is important is because as we're going into talking about more and more about artificial intelligence and using data more effectively, understanding the usage of inclusive data and data equity is also just as important. So I like the way these authors started off the article by talking about not only was COVID-19, but we were faced by Black and Brown communities, racism 20. So that is COVID-19 and then racism 20, brought to light by the murder of George Floyd by a Minneapolis police officer. So this was something that brought to light that a black person is roughly 5 times as likely as a white person to be stopped by the police without just cause, to be incarcerated or to be killed by an unarmed person. Or to be killed by the police while unarmed, excuse me. So racism has been declared a public health crisis. But one thing I wanted to bring to your attention, and I want you to go over this whole article, but is this idea of public health critical race praxis. I've been writing about critical race theory for about the last 6 years, but more recently, I think this has come to light, and public health critical race praxis is actually a guiding principle. And it really goes in and examines and analyzes health equity challenges. So race is a social construct, requires how explanation of how racism is a display of power over other things. In fact, in my other videos, I've argued it's a type of structural violence. And in doing so, the critical race praxis is calling for researchers to reflect on the questions they pose and the disciplinary knowledge they apply. So what this means really, this goes into a lot of the meaning of health inequities, just going into talking about some of the shortcomings of the infrastructure for the U.S. public health data, which was on full display with COVID-19 pandemic, with missing data on the pandemic or not timely information. And so many months later, the collection and reporting of race and ethnicity data in COVID surveillance have become a common practice, but the ability to link that information onto the socioeconomic status of affected people or the conditions in which they live, that's still limited, if not non-existent. And what I'm going to do is I'm going to give you some solutions as to how to combine those things in some ways. and give you some ideas, solutions too. So we're not going to just sit here and be discussing about problems. Then this article, the authors go into talking about Patricia Hill Collins' Matrix of Oppression. This is one I've talked about in many presentations, and this is kind of the go-to framework talking about intersectionality, and just the really, really strong role that equity plays. So it's kind of so understanding what this means in the context of data collection is what is interesting and something that is worth exploring. The author goes into also weighing the value of subgroups and understanding weighting, also understanding the context of absolute versus relative measures in epidemiology, and also understanding how intersectionality kind of plays a role in data collection. So one race might not be just that identity of that person. It may go well beyond that. So understanding, so which is why many of my research topics are from different contexts. So sexual orientation is one I've explored, race, geographies I've explored, ethnic backgrounds, educational attainment levels. You have to come at this social context from different approaches. That is the only way to understand the problem most fully. And so when you do this, when you slice the data in so many levels, this reduces statistical power. And in fact, I have oftentimes discussions with students about potential corrections, family-wise error corrections that are needed in order to correct for so many independent predictors, independent variables or predictor variables. So this is where you have to kind of make adjustments and try to make determinations as to how you will piece the problem and understand the research problem in a way that it makes sense, that you're attaining statistical power by having an adequate sample size, but then at the same time, I'm getting enough information. So now there's some data informed action that can be taken. Imagine what public discourse and data informed action would look like if researchers and practitioners routinely name the values and norms underpinning measurement in peer reviewed manuscripts, community health needs assessments, and pandemic surveillance dashboards. So standardizing such practice, encouraging the public to reflect more deeply and critically analyzing the context of inequities. So creating central hubs and discussion forums and kind of places around the university where ongoing conversations are taking place, where there's deeper understanding of topic areas, will help better guide and frame a lot of these approaches to understanding inequities better within our society. And then indirectly also address education. So I will go on to going and talking about anti-racism practice, which was introduced by Chanderford and et al. And so this is, the argument that, racism is in fact, and this was back in 2010, this was being made, is in fact causing high rates of morbidity, mortality, and overall well-being vary depending on socially assigned race. And so, as you can see, socially assigned race is being emphasized already in the first sentence. So eliminating racism is therefore central to understanding health equity. So we introduce critical race theory to the public health community, highlight key critical race theory characteristics. So this was in the American Journal of Public Health. This is what I'm trying to emphasize, which is why I think the onus is on us to really not only kind of implement in certain places, but really actively champion some of these ideas and be at the helm of many of these initiatives. So the overconfidence. This is an interesting statement. The reason structural forces drive inequities. So not the reason, but although structural forces drive inequities, research and interventions disproportionately emphasize individual and interpersonal mechanisms. So overconfidence in the objectivity of research can blind investigators to the inadvertent influence of an a priori assumption on research. So, public health framework adapts critical race theory for public health research and practice. And it's a multidisciplinary field, and you have different definitions, but in the context of critical race theory, this is different. So, centering in the margins, which is an interesting concept, making the perspectives of socially marginalized groups rather than those of people belonging to dominant races or culture, the central axis around which discourse on a topic revolves. Critical consciousness, experimental knowledge, ordinariness, Praxis, primary race consciousness, social consciousness of race. So these are some different definitions that are there. But again, going into Anderson's access to care model and how all of these play a role as well is important. So at the end of the day, it's up to all of us to make sure that even the most vulnerable populations are actually taken care of. And so they talk about the authors actually talk about HIV and how this plays a role as well. And so, for instance, and I'm going to go into the details of this one study here. There was a study between 2003 and 2005 in an urban area with high prevalence of HIV, and the racism-related factors are potential barriers to African Americans obtaining readily available routine HIV testing, as recommended by the CDC. So the HIV testing backbone of HIV prevention, after 2 decades of HIV prevention efforts, prevalence remained elevated because of it wasn't getting to African Americans, and so basically the effect was that worse outcomes, worse prognoses, and later diagnoses in HIV for African Americans. And so the focus on racism as a potential barrier grew out of this formative research. And so this diagram actually, this figure goes into the adaptation of Anderson's access to care model used as a study's conceptual model, and taking a look at how a residential segregation plays a role. And I've actually talked about residential segregation in quite a few of my videos otherwise, but how all of these external environments and healthcare environment lead to need factors, enabling factors, and also predisposing factors, population characteristics leading to HIV antibody testing. So there are these many things going on behind the scenes before HIV antibody testing takes place, and this is why something another unique theory, like the public health critical race framework, can really help guide some important research and studies. So race consciousness is really important. and informs all aspects of the project, including development of the conceptual model. Race consciousness suggested that considering the racialized social context of African Americans would be germane to research on their HIV preventive behaviors, given their historical experiences with the healthcare system and stigma linking HIV and Black race. Um, so I think the conclusions here are pretty clear. One that was actually used in this HIV transmission and HIV study was actually generalized estimating equations with logistic regression. Um, so the next study that I'm going to just quickly go over is a more recent study, and this is actually very interesting because it's now using how the idea of place-based initiatives. And so we've already established that structural racism, in fact, is a public health crisis. That has already been established. But what are solutions? I mean, how do we get to the point where we're starting to understand this not only in the context of maybe residential segregation, but also geospatial, geographic considerations, for instance, place-based initiatives, and also policy-based considerations and needs-based, food insecurity, all the different facets of the social determinants of health. How do we start to see this in a holistic way? This was the question that was posed in the initial New England Journal of Medicine article, and I told you I was going to come up with a solution. So here it is. Following the onset, COVID-19 unemployment and food insecurity were higher in predominantly Black community relative to the U.S. population. Available resources did not always align with participants' needs and were less accessible for residents without private transportation. So the PBI's response to this endemic spanned SDH sectors. So as you can see, place-based initiatives can really get in. And I've recently actually collaborated with a whole team of collaborators at Walden University to write about place-based geospatial ways that we can improve education. So place-based initiatives are really as this terminology is being used, crossroads for affordable housing, community development, and even education. Local context is very important. So 1.6 develops local context and gives you specific examples where this is used. And then this goes into some social determinants of health, needs assessment, and then even an index. So there's a social determinants of health index, and this was run in ArcGIS. And here's some of the maps. So this can be actually found through Charlotte Open Mapping Portal. And as you can see, there's some very high social determinants of the health index, and then some that are lower. So higher scores indicate higher access to social determinants of health. So the yellow parts are the bad parts. So you can go over the rest of this paper, going over the social determinants of health. Yeah, some places have high access and some places have low access, and that's the way it works. But honestly, if you look at the way that geospatial informed responses take place, these are very effective and can really be useful in understanding better and addressing social determinants of health. So, just in conclusion with this article, place-based initiatives within these two communities were wonderful at addressing and successful in addressing structural racism. And so geospatial determinants of health should be considered. So finally, there's this perspective piece that you can just kind of go over on your own, but nevertheless, pretty important to go over. Um, United States academic medical centers and United States institutions play a major role in understanding global health better. And it is really important to have kind of an anti colonialist and anti racist framework towards global health and the institutions and universities that are serving the global south. And understanding the various perspectives. A lot of the legacies of racism and colonialism in global health just continue through social, academic, and political systems. This hybrid approach and better understanding the binaries between the global south and global north, and being able to work together in a more collaborative fashion is the way that we'll be able to rectify some of these differences. There's motivations for understanding global health in a better way, in an anti-racist way. It's beyond the ideas of charity, altruism, aid, wanting to do good. These are too reductionist. It's going beyond and decentering ourselves and reimagining global health in new ways to bring better solidarity together for all of us. Thank you for listening.